Welcome to St. Alphonsus Willcast, the podcast where we explore the many facets of health and well-being. This podcast is brought to you by St. Alphonsus Corporate Health and Wellbeing and a generous grant from the St. Alphonsus Foundation. Thanks for listening and enjoy the show.
Good morning, everyone. Welcome to the St. Alphonsus Wellcast. My name is Kleaveland. I'm a family nurse practitioner here at St. Alphonsus in the Department of Corporate Health and Wellbeing. And today I'm super excited. We have a very special guest on, Dr. Jeff Bank. Dr. Jeff Bank is a gastroenterologist with the Digestive Health Clinic here in Boise, Idaho. And to give you some background, he grew up in Cody, Wyoming, and attended Carroll College in Helena, Montana for his undergraduate education, and then went on to attend medical school at the University of Washington. He then completed both his internal medicine residency and his gastroenterology fellowship at the University of Utah in Salt Lake City, where he served as the chief fellow. He is now board certified in internal medicine and gastroenterology, and he is a member of the American Gastroenterology Association, the American College of Gastroenterology, the American Society of Gastrointestinal Endoscopy, and the Crohn's and Colitis Foundation of America, which sounds all exhausting. He has a very special interest in inflammatory bowel disease, and we are so excited to have him on today to talk a little bit more about the field of gastroenterology and how it may apply to you. As a note, we also have Candi Zappia on the line, who will be chiming in from time to time with her own questions and comments, and we're happy to have her as well.
Thank you.
Happy to be here.
Thank
Looking
you
forward
so-
to the conversation. So.
Thank you so much for coming, Jeff.
No problem. Happy to be here. Yeah.
Good. So the field of medicine is so broad, and there are so many areas you can choose to specialize in as a physician. Can you tell me a little bit more about what made you choose gastroenterology?
Yes. So I was originally interested in medicine, really starting kind of medicine and the sciences starting in middle school, and knew that I kind of in high school wanted to pursue medicine, which is part of the reason I went to Carroll College. And originally when I got interested was ophthalmology because I had an interest in photography, and I still enjoy photography. And then as an undergrad, well, really, when I was a sophomore, I started to develop GI symptoms. I was having bloody diarrhea and weight loss and joint pain, and actually had a colonoscopy the day after my 21st birthday, so quite a nice present. And then I was diagnosed with Crohn's disease. And so through my experience of having really multiple gastroenterologists care for me, now roughly 8, kind of through all my medical training and traveling and things, that I got interested in GI and kind of pivoted to that. And then shadowing GI docs, I really enjoyed the field, really the breadth of it, as well as the procedural aspect, and then the ability to positively impact patients' quality of lives. And then decided, hey, I have this disease. I really want to give back to other patients like myself, and so that's really how I got interested in it. So I guess you can say that I've been on kind of both sides of the fence with medicine, both as a patient and a physician, and I love it. So.
Is that something you share with your patients too? Do you let them know you have Crohn's?
The patients with IBD who I see in clinic, I share that with some or most of them. It's not with every patient that I do that, but it's, say if a patient is hesitant to start a therapy for their inflammatory bowel disease, I say, I've been through some of this myself and struggled with the thought of, this is a lifelong disease. I have to be on medication on a lifelong, long-term basis. And so I've kind of thought about this not just from the physician side of, I need to treat a disease, but also the patient side of accepting being on a therapy that suppresses your immune system and needs regular monitoring. And so I usually will kind of throw that or offer that to the patient, but I try not to make the visit about myself, because ultimately
Right.
they're coming to see me, and I'm trying to take care of them and make a positive impact on their life.
Yeah, I think finding that balance is so important as a provider, but just having been a patient, all of us have been a patient at some point, knowing that the person that's treating you is a human and also has shared in some of that as something that I think probably could be really valuable for your patients, and they're super lucky to have that perspective from you.
I like to be able to offer it, and especially those younger patients who, you know, are, as we've been in our 20s, and, you know, you're going to college, you're doing this, you're doing that, and you want to live life. And so I try and provide the some reassurance that yes, you can lead a normal quality life. You can be a normal 20-something, 30-something year old, and go through all those life experiences that, you know, we can manage this. So
yeah, that's so great. I love to hear that. You know, it's so interesting to hear how people get into the fields that they get into and what leads them there, and that personal experience piece is pretty
yeah.
neat.
So that's my answer. We jokingly say in GI, you know, it's for the glamour of the field, but really, I mean, for me, it was the patient side of it in addition to the glamour of it. So,
Right.
Yeah.
I love
And
that.
you now get to take photos of the insides of people's guts.
I get to use my photography skills daily. Yes.
That's great.
Yeah.
So inflammatory bowel disease, you kind of touched on IBD or inflammatory bowel disease when you were chatting about that. And what other conditions are you seeing primarily as a GI provider?
Sure. So I enjoy that we get to see a really wide variety of conditions in GI. Really, it's from the entrance to the exit of the GI tract. So we're like in the esophagus. Say we're seeing patients with swallowing difficulties, and Barrett's esophagus, and stomach conditions, small intestine, large intestine, as well as liver, pancreas, and so it's really a nice variety, and that, I mean, these are commonly conditions that, I mean, are affecting people's quality of lives. They're coming in, say, with heartburn, reflux, and you know, there's different medications you can do for that, and irritable bowel syndrome is quite common. Inflammatory bowel disease is becoming more common, and you know, we're helping people, say, with fatty liver disease is another common condition that we see. So we're trying to, that has many overlaps, say, with diabetes and high blood pressure and being overweight, and so we're trying to help patients through that, and as well as their other specialists who they're seeing in their primary care doc. So it's a fun field, and a lot of times you never know what you're going to get, and that's something that I really enjoy. So.
Yeah, that's great. So something I'm particularly interested in the wellness field too is, what do you think is sort of driving that increase in prevalence of some of these GI conditions in the general public?
I think that as many Americans become more overweight, I mean, that predisposes us to getting like conditions like heartburn and reflux and fatty liver, and so I think that is in part because of it, and then also with the pandemic, I think that all of us are under increased stressors, and we're dealing just with more day-to-day stress in our lives, and so that's making the conditions like irritable bowel syndrome more prevalent, and driving that, as far as I know, I've noticed it with my own gut, as far as having inflammatory bowel disease, but also having, you know, like I have a test coming up that, hey, you know, that I'm feeling a little more symptoms that way. So I think those are partly why we're seeing more conditions, and then I'd say also our primarily Western diet of, say, you know, things like fast food and our Idaho potatoes are also. I think we're still figuring out exactly how they're affecting our gut health, our microbiome, and so I think that's the way in which I view it.
Yeah, for sure. You know, and we just are hearing so much nowadays about like that gut microbiome, all the bacteria that are living in your gut, and what that means for like your digestive health as well as just your entire body health. And I guess I'd be interested to hear from you. What are your general recommendations for people in terms of their gut health? Like, what can they do to keep their gut as healthy as possible? Sure.
Yeah, the gut microbiome is obviously an area of active research, both for, GI, but also diabetes, the obesity epidemic, as well as many other areas. And I think as far as our general GI health and kind of diet things that we can do for that, is the primary diet that I would recommend for patients is the Mediterranean diet, which is a diet that's lower in processed foods, lower in lean meats, higher in fresh fruits and vegetables. And usually this has an overlap with patients' say cardiovascular health. It overlaps with a generally healthy diet and can also help people lose weight. I recommend it to patients who are coming to me, say with fatty liver disease, as well as there's data for it in inflammatory bowel disease and irritable bowel syndrome. And then I think something that also comes up with the microbiome is the question of, should we use probiotics? Like, should I eat yogurt? Should I take a probiotic supplement? And the short answer is, if you're having other GI symptoms like bloating, cramping, and you're taking a probiotic, honestly, the patients who I see come to me with those, I usually actually stop the probiotic, because a lot of the times it's actually making it worse or contributing to it. We don't know exactly what is in the probiotics. They're not being, for the most part, being regulated by the FDA. Are they still having active ingredients? Are they refrigerated? How many colony-forming units of X bacteria are in them? We don't always know. And so I think that a lot of the times that patients think that they're providing a benefit, but many of these probiotics are just being digested by the stomach, and then really you're not getting any sort of benefit from them whatsoever. That being said, I do eat a yogurt every morning with granola and try and follow a little more higher fiber diet, which is something that has been shown to provide good gut health, and again goes along with your general kind of cardiovascular diet. Just trying to incorporate more things like granola or Fiber One or Benefiber, things like that are good for regular GI health.
Yeah, and I think I've heard too, a lot of fruits and vegetables and just minimally processed foods are going to feed a lot of the good bacteria in your gut too, right? So it's sort of, maybe you're not directly eating the bacteria in a probiotic, but you're feeding the correct bacteria. Is that correct?
That's my understanding of it as well, and less processed foods and less other kind of additives and things are definitely better for your GI health. And I think that we've all, say, had some sort of kind of a gastroenteritis or a viral syndrome, and felt like our gut was off, and then when you want to replenish it and try and put good things back in. And so I think the way in which to do that is probably more kind of a yogurt sort of based, rather than trying to do probiotics. The one probiotic that does have some data is Culturelle, and that's one that if patients want to try something, that's one that I recommend, and is generally more affordable, and you can get it on Amazon. But there's many. People come to me with all sorts of probiotics that they've tried, and I look at it and I say, I don't exactly know what's in this.
Yeah.
And sometimes they're expensive. So
very, very much so.
Yeah. Who knows what?
Exactly. And that's the other thing is, people come to me try and say over the counters, herbal supplements, but I usually ask, hey, exactly how is this helping you? How do you feel the benefit of it is? And if they can tell you, great. But if not, sometimes they say, well, I've tried this for a few months and I haven't noticed anything. I said, well, maybe it's time to stop it.
Right. That definitely makes sense. I think that also speaks to your point too about how so many people are suffering from gastrointestinal problems. Just the litany of options available for either herbal things or supplements or things like that people are trying for various ailments, all within their gut.
and there's many things over the counter, obviously, like your Pepcid, Prilosec, those kind of medications for stomach acid. There's stool softeners, antidiarrheals, and really a lot of what we give to patients or recommend is over the counter, but you have to know how to use them and how long, and but that's the good and the bad of GI, is that usually patients have tried XYZ before they come to you. So
yeah, and I'm about to touch on a touchy subject because I personally know most people on a dinner party list, if I were to invite people, have some sort of food allergy.
Yes, yes.
Or they
Yep.
have something they're avoiding, or they're,
Right.
this person isn't eating gluten, or this one's not doing dairy.
Yep.
And not in any way am I trying to discredit people's personal experiences or their symptoms, but I am curious about what the evidence is about these food allergies or these intolerances that people are seeming to have more and more of.
Yeah, I mean, you're definitely right that before you invite somebody over, you have to ask that question, and some people who come to see me, some people do feel better on a dairy-free diet. I mean, honestly, humans are the rare animal that some of us, but not all of us, can tolerate milk into adulthood. But the eating dairy generally is something that's going to be undigested or minimally digested by your GI tract, and there's a lactose intolerance, and is a whole wide spectrum of I can tolerate, say, maybe yogurt and cheese, but not milk or not ice cream, and vice versa. And so I would encourage people to, for lack of a better word, just do a trial and error with your own gut as far as seeing what you do and don't tolerate. And this should be kind of generalities, not, I can only do X brand of yogurt and not this other type of yogurt, and trying to avoid becoming so restrictive. I developed a sensitivity or a reaction one time with, say, a glass of milk, and I can't do any type of milk. That no, it's probably worth retrialing that in the future. As far as the allergy testing, I see that people come to me either with, say, blood tests or skin testing for various food allergies, and they think that that's kind of the be-all, end-all as far as, I can never have these foods ever again, and they're the cause of all my GI symptoms. And really, that's not the case. The allergy that specifically the antigen that they're testing for, either in the blood and the skin, doesn't always cross over to the gut. It's not that, and there's different what are called antigens, or kind of proteins in the blood that then present to other receptors, and so those don't always cross over to the gut. So my advice is that you do kind of your own testing at home. I mean, maybe when you don't have something going on the following day, and you try it for yourself, because I think that the danger is that you become so restrictive that you're not getting really any sort of nutrients in your body, and then you actually wind up with other disorders or deficiencies, or vitamin deficiencies in your from not eating a whole laundry list of foods. And so I think that those testings, are specifically the skin and the blood testing, have maybe some role for other specialists, but not so much for gastroenterologists.
Oh, that's interesting.
Yeah. I know that I cannot drink a glass of milk without my stomach being upset, but I can eat as much ice cream as I possibly want.
Convenient.
Yeah.
It is.
Yeah.
It's very convenient.
Yeah, and like I said, that kind of the lactose intolerance is a spectrum, and really it's something I view it as. I mean, I have it myself, and I view like, the people who can tolerate lactose they have a mutation, and that's from, I think, actually during the plague is when that kind of started to become a little more common. Is that those people who were able to tolerate cow's milk then had a kind of a survival benefit that's now kind of carried over to our Western world. And I am somebody who doesn't have that, I guess, more that
you're not as highly evolved. It's okay.
I guess, yeah. Hence why I went into gastroenterology as opposed to, say, something like plastic surgery. So.
Right. I don't know. Just don't take my brie cheese away. Anything else?
Yeah, that's good.
Brie.
It's all a risk benefit at the end of the day.
Yeah.
So. Yeah.
And it's interesting too, because it's hard even with some people say like, I can't have strawberries, or I can't, there's very specific things I hear from people too, and I personally would never know, because I never have a single food in isolation. I never am just eating a strawberry.
Correct.
I'm never just eating this. It's like always something combined and mixed up, and Anyway, it's my own personal experience.
Yeah, and that's the difficulty with it. And I encourage people to try and keep a food diary. There's a lot of different apps that you can get, and then if specifically one that has some good data. If you have, say, irritable bowel syndrome, is called the Monash University app that's available both for iPhones and Android, and that can really work with you as far as the details of all these foods, and they have some good resources on their website. There's dietitians who are trained specifically in the Monash University this is specifically more for a diet called the low FODMAP diet, which is a diet that is generally prescribed or recommended to patients with irritable bowel syndrome, and outlines foods that are more likely and less likely to cause symptoms like abdominal pain, bloating, diarrhea, and so that's something I would encourage people to look into. And then if they want to take a further deep dive into it, it's that app.
That's a great idea. So. I got diagnosed with GERD.
Sure.
Forget what it stands for. Want to tell us?
Gastroesophageal reflux disease, or usually people come in with heartburn, reflux, and
right.
So yeah.
Right. So I got diagnosed with that like as a teenager. I had to have an endoscopy and all of that situation, and I've kind of figured out like what I can eat that makes it, kind of spike up again or, whatnot. But it'd be like I'll have stretches where I'm great and I'm not taking anything for it and I'm feeling great. And then it'll come up. And I think having the app to be able to just kind of like maybe see what it is that I'm eating, or if I'm stressed, because I hold all my stress in my stomach, all of it. So, just trying to evaluate what's going on and track it so that you're more aware and then can,
Yeah, and if you could just keep mentally track of it, or on a note, or other things, like you don't have to use an app, but there are, like, I think MyFitnessPal has something, other things as well. But it's just to kind of keep some mental notes as you go along, and we have apps for everything, obviously.
Yep.
So.
Yes, we do.
There's an app for that.
Yeah. Yep.
There's an app to organize your apps now, and I'm not joking.
Oh, my goodness.
Wow.
Okay, so we've talked about the gut microbiome, bacteria in the gut, your gut health, what to avoid, processed foods, what to eat more of, foods in the Mediterranean diet.
Yes.
Let's talk about colon cancer.
Sure.
I'm always really interested in this because I know the guidelines in terms of screening and all that have changed a lot in the last couple of years. So my background as a primary care provider, I'm always sort of interested to know what to recommend to patients and whatnot too. So first, I'd love for you to just talk about why is it important to screen for colon cancer?
Sure. Yeah. So March was colorectal cancer awareness month. So we're coming fresh off of March. And as far as colon cancer goes, it's the third most common cancer in the U.S. and it's actually second most common cause of death among cancer. So it's quite common and something that is easily screened for and prevented. And the ways and now the most recent, the American College of Gastroenterology, as well as the American Cancer Society, and then the United States Preventive Service Task Force, all these have their own acronyms and abbreviations, have now all recommended that we start screening for colon cancer at age 45, and it's used to be at age 50. And so as far as how you do that is there's stool tests that you can do, either what's called a fecal immunochemical test or a FIT test, which is every year, the Cologuard, which I'm sure people have seen advertisements for on TV, which is every 3 years, or the gold standard test, which is doing a colonoscopy. And there's obviously advantages and disadvantages to each of these methods. I mean, colonoscopy being the gold standard, and something that I do all day, every day as a gastroenterologist is obviously you have to do the bowel prep the day before, which having now 8 colonoscopies myself for Crohn's disease, I can attest that it is not fun. However, it is very doable, and I think that it is not as bad as people make it out to be. You have to be on, say, clear liquids the day before, do the bowel prep overnight, then you go in, get a nice nap, and then you're all done. And
sounds easy.
I like to
Sounds
think
easy.
it is obviously easier said than done. But for patients who are at what's called an average risk screening, which is the vast majority of our population, and those are these are patients who do not have inflammatory bowel disease, family history of colon cancer or other inherited GI cancer syndromes. These are kind of the intervals for those patients. And I think that doing colonoscopy and seeing it performed on a routine daily basis is we're able to pick up say if patients come into us with symptoms, we can take biopsies, we can remove polyps right then and there during the exam and get a direct endoscopic or direct visualization of exactly what is going on or what isn't going on. And then with the other tests, the stool based tests, which are the FIT test and the Cologuard, they're good, and they're better than nothing, especially because we're seeing that really only about 2/3 of the American population is actually being screened for colon cancer. So there's roughly a third of patients who we haven't reached. And so if patients are willing to do a stool test, it's fine. But a lot of the times these tests, however, they're picking up what are called advanced adenomas, or meaning that these are polyps that are generally about a centimeter in size or more. Okay. But with colonoscopy, we can really detect polyps down to say 2 to 3 millimeters in size, and remove them.
Remove it, right?
Right at the time, and these tests are good as I'd say an initial kind of screening tests, but oftentimes then you have to have a follow-up colonoscopy if it's positive, and sometimes these tests also have a false positive or false negative rate, meaning that they either say if it's false positive, they say it's positive but it's actually negative, or if it's false negative, meaning that they actually do have, it says it's negative but there actually is, say, a polyp or something else going on in someone's colon. And so in addition, the other flip side of it is having submitted stool tests myself for my own disease, that it's not the most pleasant experience to go home and do a stool collection kit. And a lot of the times I have patients who tell me, I'd actually rather just have a colonoscopy than submit a stool test. And granted, the colonoscopy, I mean, you're taking a day off of work, you're getting sedation, but you're doing that, say, on average once every 10 years compared to once every 1 to 3 years to submit this stool test. So I think that, these other tests are out there, but I at the end of the day, I still think that really colonoscopy is the gold standard for a reason. So
yeah, and I really want to touch back on a couple of things you said there, because there was a lot to unpack in terms of the screening, and you brought up so many good points, one of which is if you have an abnormal FIT test or Cologuard, you do need to go through with that colonoscopy.
You do, and actually it used to be that insurers would not pay for that or that follow-up colonoscopy.
Right.
But actually starting in May, after the advocacy of the American College of Gastroenterology and American GI Association, the insurers now do pay for that follow-up colonoscopy.
Right.
So that's a change that's going to be happening really now in a few weeks.
Okay, that's good to know.
Yeah, because that was, I would say almost the biggest downside to those stool-based tests in the past. But now we've been able to, the GI societies have been able to change that on a government or kind of systems level. So that's I would say a very positive change for patients if they elect to go the stool-based test, and they don't wind up with a more of an out-of-pocket kind of non-screening or non-preventive exam, which they had in the past.
Right. And I love how you said so many people are not getting screened. So if the option is stool test or nothing, do the stool test. Mm-hmm. Then the other piece is I have seen so many patients who have had false positive Cologuard tests and have gone on to have a normal colonoscopy that they then spent 4 to 6 weeks sometimes sort of waiting, biting their nails, wondering what's going to happen. And that anxiety there, whereas, they maybe could have eliminated that anxiety by getting the colonoscopy in the first place, I guess. But
I 100% agree. I see many patients who come to me thinking, my Cologuard is positive, I think that I have colon cancer, or that's what I've been told, or that's what I've read on the internet. And it's a lot of undue stress, and really the colonoscopy is really nice because we can just go. Somebody's coming to you. They're not having symptoms, and you can go in, just remove polyps, and they just say, oh, great, it's all gone. And then I can go home and go get something to eat afterwards, and rather than the anxiety of waiting and saying, well, is this test, do I need to believe it or not?
Right.
And so then you have to wait for that colonoscopy. So
Right.
and generally patients are not having to wait a long time,
Right.
but it's usually can be weeks. So,
Right.
yeah.
Yeah, and again, not to discourage anybody from going through with any screening that is available
Right.
for them, because they are validated,
Mm-hmm.
recommended
Mm-hmm.
modalities. One other just question I have is, when you're doing these screening colonoscopies, do you find a lot of other abnormalities as well often, or is it just occasionally, or what kind of things would you maybe find?
Usually, in somebody who is not having symptoms, and we're doing just a screening exam, we generally don't find other abnormalities, say things like Crohn's disease or ulcerative colitis. Those are like inflammatory bowel disease. Usually patients are having symptoms with those symptoms with those diseases. And so for the most part, we're not seeing a whole lot else, but other common findings that we see during colonoscopy are things like diverticulosis,
Right.
which are just what I consider to be kind of potholes of the colon, or kind of small benign little outpouchings of the colon, as well as can see hemorrhoids. Going back to diverticulosis, it's something that we see. I feel like every other colonoscopy, and people get concerned about their risk for diverticulitis, which is infection or inflammation of those little outpouchings. And generally, only 5% of people or less end up with diverticulitis, or say potentially needed to go to the emergency department with abdominal pain, and maybe need to be treated with antibiotics. But that is a common finding.
Okay.
So,
And then, one other thing that I love to talk about too is just how screening's so important, but then also, like, say someone's had a colonoscopy a few years ago, and then they end up developing, new onset diarrhea, or they have blood in their stool or something like that. Is that still something that they should bring up to their provider and consider additionally screening or diagnosis?
Definitely. Yeah. And I think that, you start by, say, with the diarrhea, looking into, say, other causes, or screening for infection, or looking into celiac disease and other reasons for it. But then oftentimes we will say repeat a colonoscopy to see if there's any other reason that the diarrhea could be there, by taking biopsies and seeing what's going on directly under the microscope, which is really, again, the gold standard for it, or rectal bleeding. Obviously, we take seriously, and also take seriously not just in what I consider to be the screening population of the 45 to 75. It's really patients of any age, and say 20-year-olds and 30-year-olds, and whoever's having it. And we got to say, is there another reason, say, besides hemorrhoids, that it could be? And because we've lowered the colon cancer screening age to 45 for a reason, because we're seeing colon cancer more frequently in younger
Right.
people, including say 30-year-olds, and even some people in their late 20s. And we are still trying to figure out how we catch those people, but that's really the main reason why we actually lowered that starting screening age.
Yeah, I think that's population that, I think anybody with changes in stool habits and things, or other GI complaints really need to have those addressed, because, even if you're younger, you can still be subject to some of these unfortunate diseases.
Yes. We've all seen those rare patients, but they exist, and we're doing
stick
what
with you.
They do, and that early onset colon cancer is something that's an area of active research, as far as what exactly is triggering this. Is it say changes in microbiome? Is it other factors that the patients have? And so just know that that's an area of ongoing. But
yeah, and I guess my last question for you would be, what are the new hot areas of GI? Like, what are we seeing coming down the pipeline? Is there anything sort of
Literally.
I was not intended.
That's good. That's good. I like it. Yeah. I'm always here for good GI jokes. So So as far as new things, I guess in my area of interest, inflammatory bowel disease, there's a lot of new therapies that are being developed and new medications in the pipeline, and a lot of the medications that we use are either IV infusion based or injections, or what are called subcutaneous injections, either in your abdomen or your legs, and that's not always a patient's first preference for taking a medication. So there's a lot of oral medications that are coming out that are helping to control inflammatory bowel disease. For liver disease, thinking of kind of fatty liver, another very common diagnosis. That's an area of active research, and some medications that are coming out that hopefully will make more of a positive impact on that than just trying, say, lifestyle changes and dietary changes. And then as far as endoscopy goes, I mean, we are doing more through a scope than has been done in the past. As far as, we're removing large polyps, and so patients don't have to go to surgery unless they have a colon cancer or something more worrisome. Mm-hmm. And so I think those are the areas that I would say are really neat to see the active development right now, at least from my perspective.
Yeah, new ways to help your patients, and ways that are more tolerable for them or can improve their quality of life has to be great. Yeah,
it's exciting. I love GI, and it's neat to see all these new developments and be able to help people out, and if you can spare them a surgery, I mean that's really really yeah. And also, I mean, hopefully we're coming especially with IBD, and that we're hopefully preventing surgery or complications of that disease, that people can really just, like I said, lead that normal quality of life.
That's so great. Well, that's great. That was such a great conversation about what's coming down the pipe.
Yeah. Yes.
I'll use that one at least 3 more times
right.
today.
Yep.
I loved hearing about colon cancer screening recommendations, things we can do to keep our intestines healthy, and what we need to do in order to follow through with things if we're noticing changes. So
please talk to your either primary care doc or come see us in clinic, and we'd be happy to help you out. And I like to think that our endoscopies I view it as personally easier than going to the dentist, or less painful. Really the start of the GI tract is the mouth, and I appreciate the dentists doing what they do, but I like to think that the sedation that we give patients, they get a great nap, and usually wake up feeling refreshed and without abdominal pain, and so it's we think that we try to provide the best experience we can, and we have great nurses and staff, and they're really vested in patients.
Oh, that's so great.
Yeah.
Well, thank you so much. Again, that was Dr. Jeff Bank with the Digestive Health Clinic here in Boise, Idaho, answering some of our questions about our gut health and how to keep ourselves healthy. Thank you so much for joining us, and we'll talk again soon.
Thank you. That was fun.
Thanks.
Thank you for listening to this episode of St. Alphonsus Wellcast, brought to you by St. Alphonsus Corporate Health and Wellbeing and the St. Alphonsus Foundation. Always be sure to catch new episodes by subscribing to us through all major podcast platforms, including Apple, Google, and Spotify. We hope you'll tune in again. Until then, be well.